It's July 18, 2025, and this is the Room Now podcast. Hi, I'm Dr. Jack Kush, executive editor of RoomNow.com. This week on the podcast, we're going to do a few questions from you, the audience, and ask Cush anything. We're going to cover some autoimmune things, a bunch of studies like from the NHANES about rheumatoid arthritis, some Still's disease, and we'll end up with ILD. I want to start out with an announcement of something you may have already noticed. Last week was our first week of something called Room IQ. Room IQ is a quiz tool that we've been working on for almost 3 years. And it's pretty involved, but the idea is to come up with an interesting, useful, fun quiz for you. And we'll be using it in a lot of different ways, but the basic way that we're going to use this is at the end of this week, when you are hearing this podcast, probably a day or two after, you'll get an invitation to take the Room IQ weekly quiz. I want to say that like almost 800 of you took it in the first week, which was impressive. There was a bell distribution. It's a pretty simple, easy quiz to take. It's almost modeled a little bit after Who Wants to Be a Millionaire. It's a multiple choice and sometimes true false question format. It'll take you all of a minute or two, and you'll learn something from it, and hopefully you'll like it. Give it a try. My suggestion is sign into or log into the Room Now website and take that, because then your name will be up there on the leaderboard and everyone will know how smart you are. And this does get competitive at some point, does it not? Let's get back to the podcast. Lupus is always a challenge in one way or another, but lupus and stroke is sort of an interesting topic. It brings to mind the issue of either neuropsychiatric lupus, used to call it lupus cerebritis, or antiphospholipid syndrome. In this one cohort study of 40 lupus patients versus 120 controls, they looked at people who had stroke. So it's 40 lupus with stroke versus 120 controls who don't have lupus who had a stroke. And overall, having lupus in this mix is associated with poorer outcomes, especially with regard to recovery, recurrence, and mortality. So when you looked at the numbers and the outcomes, I think these people were followed for, on average, 8 years, I want to say, that the stroke mortality was higher in the lupus patients, although it did not achieve significance. But overall, all-cause mortality was 37% in lupus, 8% in controls. Recurrence of stroke, obviously higher in lupus, threefold higher, 30% versus 9%. And the incidence of post-stroke seizure was 7 times higher, 23% versus 3%. So stroke and lupus can be a bad thing. Pregnancy is always a challenge in our patients. A cohort study from the Swedish Birth Registry looked at patients who had a diagnosis of systemic sclerosis, looked at their pregnancy history pre and post diagnosis. Prior to the diagnosis, there were 94 pregnancies, I guess 978 afterwards. Bottom line is that post diagnosis, there was an increased risk in scleroderma patients for preeclampsia, 3.8-fold higher, preterm birth, also 3-fold higher, and cesarean sections, 2.5-fold higher. What was not changed was maternal risk, maternal outcomes, neonatal death, and there was no differences in stillbirth. Sjögren syndrome, another autoimmune disease, had an interesting report this week about the utility of serologic testing. You often will do SSA, SSB, Rho, and LA testing to establish the diagnosis, but it may actually have a greater import than diagnosis. It turns out that those who had SSB more so than SSA, and both were significant, tended to have more likely to have an abnormal DLCO. and that's a fairly predictive with an AUC of 0.8. Turns out that most of these people were more likely to have lymphocytic interstitial pneumonitis. And again, lung findings, low DLCO, lymphocytic interstitial pneumonitis was even more likely if you were quadruple positive. SSA, SSB, rheumatoid factor, and ANA positive. I gotta say, I don't see much in the way of Sjögren syndrome lung disease. But if I did see quadruple positive, would I worry more? Frankly, my answer would be no. But I can't argue with, cohort-based research, so now I'm more likely to take a look at this. Speaking of lung disease, one of the ones we do worry about in our patients with rheumatic disorders, autoimmune disorders, and immunosuppressive use is Pneumocystis EUROVECI, PJP, pneumonia. Interesting study showing that sulfasalazine is protective against pneumocystis in RA patients. Now, my RA patients don't have much of a risk for PJP. Hence, even if they go on rituximab, which is a risk factor for PJP infection, I'm not going to be putting them on prophylaxis. I'm not. Not in the United States, not in Dallas, Texas. But where this study was done, which I believe was in Southeast Asia, 594 RA patients with 800 plus treatment episodes, almost 200 on sulfasalazine, 600 not on sulfasalazine, with 850 patient years of follow-up. There were a total of 21 episodes. This is a high-risk population based on area or population. 21 out of almost 600 patients had PCP, PJP. 3 died. And it turns out if you were, the 1/6 of the population that was treated with sulfasalazine, there was a significantly lower risk, P.003, rate ratio 0.05. I find that surprising, but also encouraging. There is an antibiotic component, is there not, to sulfasalazine? Maybe that's why you're seeing this. 2 reports about NHANES. NHANES looked at over 38,000 patients trying to see if there may be risk factors for developing RA based on commonly available labs like neutrophil to lymphocyte ratio, platelet to lymphocyte ratio, monocyte to lymphocyte ratio, other things called a systemic index or SIRI. They looked at NPAR as well. NPAR is the neutrophil to albumin ratio. Never seen this one before, but the results are interesting. 38,000 people at NHANES who were followed with questionnaires for about a 20-year period. They found that an elevated NPAR, neutrophil to albumin ratio, was a significant risk factor for the development of RA. Comparing the top tertile to the bottom tertile, a 27% increased risk, especially if the NPAR value is over 13.6. It seems like a lot of letters and acronyms for what seems like a significant but small benefit. But this is the kind of data that you can apply to populations, that AI can apply to your population and tell you who might be at risk to develop rheumatoid arthritis. Now, this was done in all people in NHANES, nurses, women. But what if same analysis were done in people with clinically suspect arthralgia? Maybe they'd have the same things. I like that kind of data. I like that kind of thinking. NHANES also studied the risk of kidney stones in RA. I'm adverse to this right from the start. I always teach there's a negative relationship between RA and gout. If you've got RA, you're not likely to get gout. If you've got gout, you're not likely to get RA. But you and I know, because we're experts, right? Are we not? We see tons of both. There are a few people that do have RA and gout, estimated to be less than 8%, depending on whether you're looking at RA populations, and probably less than that if you're looking at a gout population. I don't know. It's kind of screwy. I like the teaching point. You can't have both because I'm usually teaching primary care, internists, people who don't see the volume we see, and they're just screwed up by the clinical presentation. Do a rheumatoid factor, do a uric acid. That'll help you figure it out. But here, NHANES, again, 19,000 people, followed for 20 years, almost 1,500 who had RA. The prevalence of kidney stones, which I often relate to uric acid and nephrolithiasis, was higher in RA. 17% of RA patients had nephrolithiasis, and versus 8% in the population. A 77% increased risk, and that was significant. So, that RA patient with flank pain, I'd still want to think, does it really RA? Could they have gout? But this says it can happen. Interesting. Another RA study I published this week. I published it because it says something I was saying 15 years ago, 20 years ago, and that is an RA patient who goes in rapid remission on anything, on, sulfasalazine, methotrexate, a JAK inhibitor, while playing Tetris, it don't matter. If they rapidly go into remission, they're going to have better outcomes. So rapid responses, I was trying to convince a company long ago, company and drug will remain unsaid. I did an impassioned plea. Rapid changes in -28 CRP within 6 weeks would predict ACR 70 and better responses. They never did the analyses. There have been a few reports that have sort of suggested that point. In this study, 865 RA patients who were being treated, and the outcome measure they were looking for was a DAS-CRP of less than 2.6 in less than 12 weeks, not necessarily rapid, but we'll just call it an early, maybe fast response. That occurred in 28% of this cohort of nearly 900 patients. And it turns out that those who met that criterion at week 12 were more likely to have better responses at week 26. Rapid remission, again, -28, less than 2.6 by week 12, was associated with significant downstream 5-year benefits with better outcomes with regard to swollen joint count, tender joint count, fatigue, hack, pain, function, most patient-reported outcome PRO measures. So I'm reporting it because I was right. And I like finding data that proves the story that's in my head. I'll report, by the way, stories that disproves the stories that I have running around inside of me, but this one was a win, and let's be happy today. Two studies on Still's disease, one a biomarker and one coming from a select population. This is from the island of Martinique. It's in the Caribbean, where they have largely an Afro-Caribbean population. It's a mix of many cultures with a lot of African culture in there. This is a study of 350,000 individuals between 2004 and 22. They diagnosed, and in this report, talk about 33 cases of Still's disease, 71% female, it's usually half-half, 80% with systemic disease, 20 with articular disease. When it settles down into articular disease, that's no longer acute Still's. That's kind of like what happens in the 20% who continue to have arthritis after the systemic disease died down. But anyway, in their collective experience, it's 80% and 20%. 91% met Yamaguchi criteria. Interestingly, the thing that really differed in this population was they did have more women. They did have maybe a few more older than 35. Half the population was age 35. I think it should be about 80+% are under age 35. And we're seeing that in a lot of Still's reports in the last few years. There's been a skew towards it being described in older people, which I don't necessarily buy as being valid. But if they meet Yamaguchi criteria, 9% didn't here, and they're 53 years old with the onset, I guess I could go along with that. The other big finding here was they had a very high percentage with pulmonary disease, and that was 51%. Pulmonary disease as manifest as pneumonitis is going to be in less than 20% of adults with Still's disease, right? Pleuritis is going to be like 30-40%. But pulmonary disease, 51% in this Afro-Caribbean population. And those people were largely 95% systemic pattern onsets. The overall prevalence was 7 per 100,000. And again, so a lot of this is really in agreement with the worldwide descriptions of Still's disease, except for this: why do they have more women? Why do they have more older people? And why do they have more lung disease? Again, we adults don't see a lot of lung disease other than pleuritis. The pediatricians that are seeing systemic JIAs, also called Still's disease, will teach us that this is a big problem, that it can be seen in up to 20%. They worry that it could be a DRESS syndrome, a drug reaction, maybe to our IL-1 or IL-6 inhibitors. But the lung disease manifests in multiple ways. It's, alveolar proteinosis, it's ILD, it's a whole bunch of different diets. So it doesn't have one unified pathology or one clear-cut risk factor or whatever, but they're seeing it and they're worried about it because the outcomes are not good. Pay attention to the lung disease. When I did my first report on Still's disease, 21 patients from the University of Pittsburgh in 1984, my good buddy, Oren Traum, was on the same podium talking about his 20 plus patients from UCLA, I believe is where, or LA County Hospital, describing lung disease. So it's been out there a long time. Another study coming from a Chinese cohort looked at a new biomarker, UBE2D1. Maybe you won't be able to fall asleep at night because I got that in your head. But this was identified by doing basically RNA-seq and bulk RNA-seq analyses in a good-sized cohort. They found that this marker, that's a protein that's found, the product of monocytes, it activates monocytes, it reflects enhanced monocyte activity, monocytes being the garbage pails that have tons of pro-inflammatory cytokines and inflammatory mediators. I'm not surprised it's elevated. But what they did find that this was not only correlated with systemic disease activity, but was superior to other biomarkers, including ones that you use. The S100 proteins like calprotectin, IL-18, which we might be using more of in the future, and ferritin, which you all do. I wonder if this UBE2D1 may be a marker for MAS, like ferritin and IL-18 can be, when those are very, very high. But they actually suggested in the paper that that was not the case. So, like finding biomarkers on a disease that's hard to understand. But anyway, let's move on. MDA5 dermatomyositis, interesting cohort, not restricted geographically, found worldwide. This study of 176 patients who were MDA5 positive and versus 55 controls looked at with other diseases, found that the presence of type 1 interferon or alpha interferon antibodies was seen in 18% of MDA5 patients, and those who had it were more likely to be older, greater than 60. They were also more likely to have one of the worst manifestations of this particular cohort, and that is rapidly progressive ILD. It's found for those positive in 68% who were positive versus 41% in those negative, so a 50% increase at least. And they also had more pulmonary infections, 71% versus 46%, and a high number of opportunistic and fungal infections that were significant. So I like this kind of research. I think I would like to have access to testing for how active is type 1 interferon and what's going on in my patients. I think it could help inform A, the treatments we might use, and B, maybe the things we should worry about. Two more reports, one from the CDC and MMWR. 1 in 5 patients with arthritis don't know their diagnosis. What? Again, another NHANES study from 2020 that found that the overall prevalence of any kind of arthritis, as reported by the patients in adults, was 67 million. That's the highest number I've seen so far, or 27.9% of the population. Chronic arthritis is still around 52, 53 million. Who are these 67 million that they're identifying in this survey? 33 million with osteoarthritis. That's kind of on par with what's been reported before. 27 million comes to mind. Psoriatic arthritis, about 1 million. That's kind of on par. Rheumatoid arthritis, 10 million. 10.6. Sorry. Consistently for the last 20 years, the number of people, prevalence of rheumatoid arthritis in the U.S. is, 1.3, 1.6, not 10 million. So there's an inaccuracy here, is it not? So these are patients reporting on their diagnosed arthritis. But the interesting thing is that 21.6%, or 1 in 5, did not know their type of arthritis that they had. That amounts to 14 plus million don't have a diagnosis. Not likely to know the kind of arthritis you have is higher still, a little bit higher, 5-10% higher if you're Black, Hispanic, Mexican American, of low income, less education, and with no health insurance, where the percentages go up from 21% to 27 to 36%. Again, this is disquieting. There's knowledge gaps here that only you and I can fix. But patients have to have the initiative to find out their diagnosis, and we need to be clear. There's a lot of people being told they got rheumatoid when they ain't got rheumatoid, according to this data. What you need to know is that National Health Interview Survey projects that arthritis will increase by 2040 to 78 million Americans. My last report is on interstitial lung disease and the risk of cancer. I'm featuring it here because I want to let you know that in the month of September, we're going to be doing a campaign, a month-long campaign on interstitial lung and autoimmune lung disease. I think you're going to like it. We're working on it now. There's a lot of action in this area. This JAMA report comes from the Swedish registry of 5 million Swedes, amongst whom there were 14,600 plus with ILD. When you look at the risk of lung cancer, it's like 26 per 100,000 if you don't have ILD in Sweden, but 355 per 100,000 if you do have ILD. After a lot of adjustments and analytics, that the overall hazard ratio risk is a twofold increased risk. The point here is, I don't want my patients to get ILD. I should be looking for it, and when it's there, not only should I consider what I can do to be aggressive or how I'm going to follow it, I think the findings should also prompt you to consider a risk of lung cancer. And it turns out it's all kinds of lung cancer. We'll end with two Ask Cush Anything reports. I'm going to just read them. Dr. Magdi Iskander from Ohio sent in a recording asking, what do I do about stopping and restarting upadacitinib in a patient of his who is going to Peru and needs to receive a yellow fever vaccination, a live virus vaccine. So this came up with the CDC and their advisory committee and vaccine advisory committee long ago when we had a live virus zoster vaccine. And how would you do that? And I think the rules first apply in that the patient should be, if there's a risk of reactivation based on the patient's being immunosuppressed or the drugs that you're using, then you should be off the drug before you get the vaccine for up to 30 days, get the vaccine, and then restart the drug 2 weeks later to allow the vaccine to work. Again, the idea here is that anticipated immunosuppression raises the risk of dissemination of a live virus as opposed to the protection afforded by the vaccine. But now you got to think of a few things. So I always teach people that if someone's going to get a yellow fever vaccine and they're going to a place where yellow fever still exists, where are they going? Are they going to be staying at the Taj Mahal Hilton, or are they going to be working in Calcutta with poor people and where there's a much higher risk of getting it? If they're going to be a traditional tourist, they don't really need the yellow fever vaccine. And you can write a letter that says, my patient's immunosuppressed, taking immunosuppressives that are life-saving to receive this vaccine poses much more risk. This patient can travel without the vaccine. And that will suffice so that they can get their visa to go. Secondly is, what is the rules here on a patient on a JAK inhibitor? JAK inhibitors are fast on, fast off drugs, much more so than TNFs and rituximab and things like that. Can this patient go off of a JAK inhibitor for 3 to 4 weeks? JAK inhibitors start to have their effect in 2 weeks. The people who go off JAK inhibitors start to get worse at 2 weeks. So can your patient be off of a JAK inhibitor? I would use the rule that I use for methotrexate, meaning I want to stop methotrexate for a week, give the vaccine, and then a week later I give the methotrexate, and no one will flare with methotrexate. With a JAK inhibitor, I'd want them to be off a JAK for a week. I'd give them a vaccine, and I'd start a week later or 2 weeks later. But this is a live virus. Again, the question is, what's the real risk of live virus infection and where they're going? If you don't know what else to do based on what I've said, ask an expert, ask a vaccination expert, ask a infectious disease colleague. Another question and recording from, and thank you to Dr. Iskander and also Dr. Samaya Shah from Pakistan. She asked a question about a patient with CKD who was unable to take a bisphosphonate, was on denosumab, received, I think, up to 10 years of therapy with improvement in the numbers. I would assume that means the DEXA scans. But the question is, what do you do after? What can you use? She says we can't give bisphosphonates. Bisphosphonates are cleared by the kidney. There are rules about using bisphosphonates in people with CKD. If this patient can't get a bisphosphonate, can't give a bisphosphonate. But there is, so a few things. Well, the first thing is, I'm not an osteoporosis expert. When I have questions like this, I go to my partner, Catherine Dow, or I call Stan Cohen, or I call any of the great osteoporosis experts in our field, including Nancy Lane up in Sacramento. But I do know enough to manage these situations. I do know that denosumab has a really long half-life, and even after you stop it because you need to do a drug holiday, there's not much benefit to a bisphosphonate after 3 years of use. And then 3 to 6 years, you should stop and do a drug holiday. But it's got a long half-life. It sticks around. That's not the case with denosumab. You stop it, it's quickly out of the system, and then they have this rebound in bone loss and a higher incidence of fractures. So you're right in saying these people need something else. So what are your options? 1, refer to a CKD specialist. 2, refer to an osteoporosis expert. Consider the use of anabolic therapy post-denosumab. That would mean using a parathyroid hormone analog or romosozumab. So again, I really worry about the rebound effects here.